When a clinician goes into a critical care area, having no experience in any other areas, they get scared about the clinical nature of things. People get scared about the monitors, the lines, the IV lines, the daunting nature of that patient. Hello, welcome and kumusta. Thank you for joining me. This is How, your occupational therapist, and welcome to OT Conversations. I have just been thinking and mulling over a better way or a good way on how therapists can get better at working in critical care. One of the challenges that I see is that a clinician is overwhelmed by the clinical nature of the workplace. And the clinical nature scares them. Mind you, these clinical challenges and clinical foundation skills and the medical foundation skills should not really scare a therapist. It should be expected that when they go to the ward and to the unit, that they should know what they're going to encounter. But the shortcomings here is chronic, and the shortcoming is in the teachings of the university. And it's leaving clinicians to just be responsible instead of the universities putting a structure on the learnings that clinicians should have. But set that aside, that's a different scenario. When a clinician goes into a critical care area, having no experience in any other areas, they get scared about the clinical nature of things. People get scared about the monitors, the lines, the IV lines, the daunting nature of that patient wearing hospital gown, looking disheveled, having some pipes and tubes and intubations and tracheostomy and NG tubes, lines, arterial lines, central lines, all of these things. It is quite daunting. And a clinician then is put off by doing something because of the clinical nature. So science is making it difficult for OT to come near a patient. If you remember, occupational therapy was not originally built on the science. The science followed. Occupational therapy and the concept of occupational therapy started with humanistic treatment, humanistic approach. We started treating people with dignity. We started talking to patients, those patients who are in mental health facilities. We knew that when you visit and when you see a person and you get a person to do something and to engage and get them have meanings, give them purpose, then the person recovers much better. So we started on the humanistic side, the well-being side, and we should consider having that as a frame of reference, as a frame of mind when we are working with our patients. So here's my tip. If you are a clinician and you're working in a highly clinical area, don't think about the science first. Just think about your patient being a person, and you, as a person, just think that you're coming in, checking up on a fellow human being, and asking how the person is if they're able to communicate with you. It is the gradation of interaction. Start with you as a person, looking at another person who's not well, and you come in. Then you start to learn about the patient. And then you start to do the things that you can start to do. Start with just looking at you. followed by a simple acknowledgement that you are there. So by that, you're already checking the visual component, the attention, the functional communication. And then start out if they can understand you. Check how they are, how they're moving their arms. Now you are checking their motor skills. So it is a gradation of input. And then you can now check the status of their hands. Can they grasp? Can they let go? Check for the status of their arms. Can they lift it up overhead? Can they cross their arms? Can they reach? So all of these things you need to factor in. And then their legs. Can they sit up? Can they roll? So this is the gradation of input. And once you think about that and you start to establish a patient's interest, and you know that they're weak, then you can start to design your session. You can start to think about things that you needed to do. And then you can factor in what kind of approach would you want to provide, or what service you want to deliver. Are you going to do adjunctive therapy? Is the person going to need performance component or enabling activities? Or is the person going to need supportive therapy? And you don't just give that as a one-off during the day. You need to give consistency to it. You need to be present all the time. You need to develop that routines and habit, a schedule. Remember, with OTs, we factor in the roles and habits. And roles and habits are very important to engagement and to doing. So if you try this approach, perhaps there is a chance that your experience in critical care will be a lot better, and it'll make you a better therapist. It'll allow you and it will enable you to help people. And at the end of the day, those are the ones, and that is the one that matters the most. Science is one thing, but helping a person from one clinician, one person to another individual, that is what is really important. And I hope you find this enlightening, and I hope you learned a little something today. Until next time, bye.
If you enjoyed this podcast, talk to your friends and colleagues about it. Like it, subscribe, share, and do what you can to appease whatever algorithm that is at play. Just remember, guys, anything you do matters and has an outcome. Until next time, bye.